All right, I'll get the show on the road. My name's Sam Biondo. I'm the Executive Officer of the Victorian Alcohol and Drug Association. We're very pleased to be part of this event today. It is a critically important area of social policy. The dynamics and the interest and the amount of effort that's gone into seeing the establishment of an MSIR in Melbourne and in Victoria over recent years has been enormous. One of the significant players in this is a person who I'll be introducing, Peter Wern, who I've known for some 25, 30 years. He's been an absolute warrior in this space, dogged in his pursuit and fundamental in its establishment. I'd like to hand it over to Peter.
Thanks for your kind words, Sam. They always say that success has many parents and failure is an orphan. So we stand with many people in celebrating the establishment of this amazing initiative, which is the medically supervised injecting room. But before we start, we should also acknowledge that we somewhere in Australia, wherever we are meeting on traditional owners' land. And we would like to pay our deepest respects to the elders of that land, to the enormous traditions and culture and spiritual nature of the custodianship that those elders of many generations have had in caring for that land. And we acknowledge that enormous contribution that has been going on for thousands of years and continues to this day. We acknowledge all emerging leadership of First Nations people across Australia. And we also pay our respects to any Aboriginal or Torres Strait Islanders who are part of this forum today. And we look forward to the day when Aboriginal ownership and custodianship is acknowledged in our Constitution, and proper reparations and acknowledgement is made both in our Constitution and law and in the ethics of our country. So our respects to all, and Black lives certainly do matter. So welcome to this forum today, where it is with great privilege that we introduce Professor Margaret Hamilton. And before Sam introduces Margaret formally, I'd just like to say that Margaret has been a giant of the drug and alcohol and harm reduction world in Australia, if not the world, for many years. And Margaret has been a leader in both thinking and practice in the area of treatment and harm reduction for so long it doesn't bear thinking about. Margaret was given the enormously difficult job and contentious job of running the review of the establishment of the medically supervised injecting room. And she chaired that review, and I think it is an excellent piece of work. And Margaret agreed, I think, 7 months ago, to when she was able to, after the review was presented to the state government, to come and present her thoughts about that review and about the process of the review. And it was great privilege and great respect we introduced Margaret. And Margaret, I say is someone who has been acknowledged throughout Australia as a leading expert in the area of harm reduction and AOD. Welcome, Margaret.
Thanks, Peter.
I'd also like to add to this by saying that at some point when the history of alcohol and drug policy is written, there'll be a whole chapter or more devoted to the work that Margaret Hamilton's put into the alcohol and drug space in Australia. She's made a fantastic academic contribution and a policy contribution. For many years, she headed up Turning Point, and a whole generation of academics and social policy initiatives have got her influence written all over it. So Margaret, I won't say much more because I could go on, but welcome aboard and thank you for doing this today.
Thanks very much, Sam. I must say, when I was listening to this, I was reminded of the ending of one of the reviews I've done in the last 15 years, which was the review of the place of alcohol in the culture of the Australian Defence Force. And I'm now known with much frowning and angst because of what's become called colloquially the Hamilton alcohol tax, of which I am most proud, I have to say. So how one leaves a sector is always kind of challenging. I think that this particular task of chairing this review, it was at a time when I'd already decided to retire from alcohol and drugs. I did think, though, when I received the call asking would I do it, that perhaps this could be the, as you said, the term bookend, Sam, before. I thought, well, I think I kind of owe it to the work that I've done over years, and I owe it to the sector, and I owe it to people who use drugs to try and puzzle over this injecting room. I was not persuaded or convinced that it was necessarily the one that we needed. It's certainly true that I'm on record as having been supportive of the principles of having injecting rooms or injecting facilities of some sort available to people who, for whatever reason, continue to inject their drugs. And so I decided to take it on. I'm speaking today still really as the chair of that review and in a sense representing the consensus report that was written, which I both agree with and I am quite proud of. There was a lot of work went into this. So rather than retirement, this was like full on, full time, effectively, though that was not necessarily what was anticipated when the deal was originally struck. So just to introduce the panel very briefly, I was there as the chair. Throughout the time of the panel's existence, I was accompanied by colleagues John Ryan, who was from the Pennington Institute, that many of you will know. Dr. Alex Cockram was engaged with us for many, many months, and she came with a mental health, psychiatry, and health administration background. And she was whisked away to the Royal Commission on the Mental Health System here in Victoria, so was unable to continue. She was replaced by Mr. Ken Lay, who had been the previous Police Commissioner of Victoria. And I thought that was an excellent combination to have had Alex as a psychiatrist available to us, and then to have Ken on law enforcement available to us. It was fortuitous, and both of them made significant contributions. Ken, unfortunately, was whisked away to become Commissioner for the bushfire recovery effort in Victoria early this calendar year, so in January. And in anticipation of that, and knowing that that might well happen, we had approached Dr. Ruth Vine, who was appointed by the Minister as the final member of the panel, who then saw through from January till we finished in late June, early July. Again, with a mental health psychiatry background, who had also been the chief psychiatrist for Victoria in the public service, but had also been responsible for running, managing and overseeing mental health services in a significant region here in Victoria. So in terms of the history and the context, we had quite a broad representation. My own history in the geography probably started before I started work in the area, but I actually started 50 years ago this year at St. Vincent's Hospital in the Department of Community Medicine, as it was then known, which incorporated the special clinic, which was the euphemistic title of the alcoholism clinic. I was there for 7 or 8 years, and during that time, I was part of the group that set up the Fitzroy Social Service Council and became very engaged with homelessness services, the Brotherhood of St. Lawrence and their family project, the relocation projects of people who had been taken from what were regarded as the Fitzroy slums and called that, and replaced with the then Tower public housing blocks that became the Atherton Gardens. So I was kind of on the ground in Fitzroy in particular, but also Collingwood, Smith Street, and to some extent Victoria Street, before it became the hub of the Vietnamese restaurants and other businesses. So my very first research in this field was looking at the people who came to what was called casualty, which is now the ED department. And what is it that brings them there? And why are we not intervening earlier and doing something about that? That led to me becoming very engaged with people who had started in those years, 50 years ago, to use things other than alcohol. And so I was involved in the very early citing and responding to people who were using opiates, subsequently hallucinogens, cannabis, and various other things. And so I never chose to work in alcohol and drugs. I've never made that choice that this is what I want to do for the rest of my working life. But here I am trying to retire 50 years later. I returned to that area very fully when I was the founding director of Turning Point Alcohol and Drug Centre in Gertrude Street, and ran a service that had both harm reduction, treatment, research, education and training, and provision of support for people in the local geography, and worked very hard at the education, training and research foundations. I went from that after 10 years, when I thought it's time for someone else to have a go at that, to chair the Multiple and Complex Needs Initiative. I won't say more about that, but I think it's becoming increasingly important. And now my only ongoing role is as a community member of the Mental Health Tribunal, where I sit once a week for a day. So say something briefly about the process and the approach of the review. Having met the other review panel members, I was very committed and very determined that we try to identify what evidence might be available to us and what, who were the audiences for our report, all within the terms of reference which had been set and are included in our report. We did identify and publish our review framework and how we intended to proceed. We commissioned 2 pieces of specific research, once repeated, which was the community survey of local residents and businesses, and that was repeated about 1 year later. That was our best effort to get a before and during. I don't think we could call it the after. Look at how local residents and local businesses had experienced the injecting room. We also commissioned some work from the Burnett Institute using their Supermix study cohort, which was a cohort of people who inject drugs that has been in place now in Victoria for many years. And we thought that would allow us an opportunity to have a look at what were those folk doing before the injecting room was opened and then sometime later. And then there was a lot of other data that we accessed and spent a lot of time looking, analysing, getting expert advice on analysis and so on. We had a lot of meetings with service users and users of both the injecting room and the North Richmond Community Health Service, and also staff of both of those services. We also met with a number of organisations and people that we thought were important in delivering services or trying to understand the needs of people who needed services in the geography. And we held a series of community consultations in about August last year. We met with, and I walked, talked, ate, had coffees, pondered, and spent time about once a month. I just went for a wander in the zone, so to speak, along Victoria Street, north and south of Victoria Street, down to Bridge Road and Church Street, sometimes down to the river, and then across to where Sam's office is, a bit further up going towards Victoria Parade. So we met with a lot of organisations who are named particularly in the acknowledgements of our report. Our big effort was putting all of this together. There is no simple or easy way to evaluate a service like this. So the last thing I'll say about that is that this was a report done on the basis of the data available to us at 18 months time. So, you know, we're getting closer to the end of this weird year that we're all in, but we had to draw a line in terms of collection of pretty much all the data by December last year to be able to try and bring it together. So a lot of the detail of that work, the analyses, the specific figures are in our report. So I won't spend any time on that, but that's what took up a lot of my time and a lot of effort in trying to ponder, understand, put together these various sources of evidence. And there were some things that I thought we would find that we probably didn't, and some things that I didn't expect that we did find. And I know you'll now say, well, what are they? I can't pluck them off the top of my head, but that may emerge in our discussion. So I think that's probably all I've got to say about the review, the panel, and our approach to the actual task. We met at least once a month, sometimes more frequently, but we had a lot of other meetings in the community and a lot of other data to get through. Thanks, Sam. Or Peter, actually, I think you're responsible for us.
Yeah, thanks, Margaret. Look, it's my pleasure now to ask Sam Biondo to make a few comments just about the overall AOD and harm reduction sector in Victoria and the lead up to the establishment of the Injecting room.
Thanks, Peter. Look, you know, the story about the establishment of the MSAR certainly fits within a very interesting context. The people may remember the background of, and I think Margaret touched on it in terms of her work at St Vincent's Hospital and in the alcohol and drug sector and the emergency department there. The issues have been around the inner suburbs and across Victoria for many, many years. The thinking around what makes a difference is often very clear in alcohol and drugs. The approach which the community and government takes to start to address these issues is often really convoluted, illogical, and fails to actually think in a pragmatic and implement in a pragmatic way. What we were looking at over a number of years was an increasing amount of harm arising from all sorts of alcohol and drug misuse. And in this case, there was a substantive heroin use historically in the city of Yarra, as well as growing pockets across Victoria. None of this is a surprise to anyone. There was a lot of agitation historically to try and see something established, looking at European models of addressing the issue, which started to bubble up in the policy space. Much of this work was focused on trying to reduce the amount of harm, trying to reduce the number of deaths, trying to address what the coroner had started to identify in terms of a ballooning number of deaths that were happening in particular circumstances, in particular locations, much of which still continues in other parts of Victoria, but it was particularly bad in the city of Yarra. The coming together of thinking between harm reduction and treatment sectors with a continuing focus on what needed to be done eventually started to get clarified, and there was a whole community push for this to occur. You know, VADA and many other organisations were pushing for this. Local government was pushing, the Yarra Drug and Health Forum was pushing, you know, there was academics, there was a real convergence on what needed to be done. The interesting thing of what happened out here in North Richmond is that we established a site right in the epicentre of where it was needed. This is quite important because you actually address the situation in situ. There are a range of other remaining issues, some of which have started to now come to the fore, is what do we do about the rest of the state? What do we do about other communities? And I think we're starting to see some very interesting steps going forward in relation to this, with the discussions of establishing a site, say, in the City of Melbourne. And that'll be an interesting debate to see develop, of course. The nature of what they established in Richmond was really quite important because there was a whole linkage with opening up the availability of allied health support and access to treatment, better pathways and relationships to assist people. And what we've started to see is that not only were we assisting people in using a facility where they could use drugs more safely, under supervision, but also accessing them into other allied health supports to address, say, hepatitis C, or dental work, or other health issues which for so many years had been ignored. And people, because of the stigma, because of the lack of access, because of continuing existing failures in primary health access, weren't being seen. So I think the history and the context of where this MSIR has come from is really instructive in terms of successes that can be gained in driving numbers of deaths down, reducing the harm, and starting to address the fundamental issues in the health and even in the amenity sense in particular communities. It's better to provide a service which is seeking to keep people healthy and safe, rather than, unfortunately, picking up the pieces in the street and taking them to hospital, or, as so often happened, to the morgue. So, look, that's the end of my little contribution here. I'll pass it on to Peter.
Thanks, Sam. I'd like to introduce Sally Mitchell now. Sally Mitchell has been an executive officer of the Yarra Drug and Health Forum. She sits on the executive of the forum now, but as a local resident. Sally's going to talk about a little bit of the history of these issues within the City of Yarra. Thanks, Sally.
Thanks, Peter. So I'll just start with a little bit of background for the Yarra Drug and Health Forum. I'm assuming that some of the 150 people who are currently online may not know all of the background of Yarra Drug and Health Forum. So the forum started in the mid-1990s when there was a lot of visible drug dealing, so a street market in Smith Street in Collingwood. And there was distress from local residents, from some of the traders in Smith Street, about the level of activity there, and the forum was formed to talk with those people between local services and the people who are experiencing the impact of that activity, and try to come up with some resolutions and some ways of addressing those issues. In 2005, Yarra Drug and Health Forum started to hold some community forums in the evening for community members to come along to and to talk about issues across the whole of Yarra that might have been impacting on their lives. Those forums were attended by residents, by traders, workers from local services, the police, City of Yarra, Department of Health, as it was then, Health and Human Services now, and also from time to time we had people who used drugs who would come to those forums as well. The purpose was to hold discussions, much as from the early days of the forum, to have an opportunity for people to discuss their local concerns and to work together, thinking that people with different opinions and different experiences would be able to work together to come up with some solutions to the problems that they are experiencing. And it was a very respectful way for people to sit and have discussions together. Each forum had 2 or 3 presenters who would also be presenting different perspectives on the issue that was being discussed. And from there, we then opened it up for discussions amongst the community members who were present. About this time in 2005, we held a forum at Richmond Town Hall. That was because there was much more drug activity on Victoria Street, and there were concerns from people in North Richmond about the impact of that activity on their local community. So we met at Richmond Town Hall as a local venue that we could use where people could easily access it. And we had a number of speakers there. We talked about the data of how much drug use and what sort of substances people were using in Richmond that we could get from statewide data. And we had a presentation from the person who was the Superintendent of Police for the area at that time. And he spoke very clearly about the City of Yarra's position in terms of drug activity and particularly street markets for the purchase of drugs, and talked about the location of Yarra in relation to public transport systems and the road network, and basically said to us there's not going to be an easy fix to this, and we need to be looking more broadly about how we can respond to this issue. We then opened the floor up to questions and discussion, and we had some really interesting comments from community members who were saying people are injecting drugs in public places in our community because they haven't got anywhere else to go to do that. And we need to provide somewhere for them to be. That night we had some people who injected drugs within the participants, and they spoke very clearly about their need for services, but also that if there was a place for them to go to use drugs, they would use that facility. So at the end of that meeting, it challenged us as Yarra Drug and Health Forum to think about how do we respond to this issue. We commissioned a number of pieces of research over a few years. Excuse me, I just need a mouthful of water. And the results of that research were that we realised that we needed to come up with some local solutions to a local problem. We couldn't just look at what else had worked in Australia or overseas. We needed to look at the particular circumstances for the City of Yarra and look at what we needed to be doing to respond to those particular circumstances and what we were hearing from people who were around in the City of Yarra. We did a lot of work. We had a whole project that looked at working with and talking to people who were using drugs around that area of North Richmond. And what became very clear from that was that we needed to be making sure that we were responding to a really complex set of needs that they had, that it wasn't just about somewhere to go to use drugs, there were other supports and things that they needed as well. And it was also clear from those different pieces of research that we really needed to be looking at community amenity and what the impact on local residents and other people in the community was of having a lot of drug activity in their community. So based on that research, we commenced advocating for a facility for people who use drugs in that area, feeling that there wasn't enough support for them at the moment, and feeling that having some access to a service would also have an impact on the community amenity. So there was a long time between 2005 and 2018 when the MSIR finally opened. And we looked a lot at other things in that period of time in terms of other strategies to address drug activity, but we continued to advocate because we could see that there was a need in that community and that it was a response to a very localised issue. We were really pleased when we heard the announcement in 2017 that there was going to be a facility in North Richmond. And we were also really pleased to hear that that facility was going to have a very thorough evaluation, and that evaluation would be looking at the benefits of the service for the people who are using it and the reduction in harm to them, but also that it was going to be looking at community amenity and the reduction in harm within the community as well. So we were really pleased to hear that Margaret was heading up that evaluation, and I guess now we have an opportunity for those people who haven't read her report to be hearing some of the detail of that. So thanks very much for everybody for coming and hearing from us today. Thank you.
Sally, thanks very much for that. That'll save me painting the picture of our effort to look at the history of that particular location. I think that some of what has occurred in Victoria Street in Richmond has been associated with, and people have written about this, what had happened earlier in Fitzroy and Collingwood, and then the effort to clean up, if you like, the so-called drug scene on Smith Street did contribute, I think, to some displacement. And this is often the case. And if we look internationally, efforts to just crack down hard, have a lot of policing, have a lot of monitoring, tends to mean that difficulties and the drug market and drug scene, if you like, pops up elsewhere. And so Victoria Street is in part a consequence of what occurred in the Fitzroy, Collingwood area a bit earlier on. But I won't say much more about that. I think there was certainly, when we looked at it, a lot of evidence for why that site was chosen. I think that the particular selection of the specific site was not part of our terms of reference. I think there were some fair enough and reasonable reasons. Obviously, the one about it being the most concentrated heroin marketplace and therefore likely injecting drug use and people using it by injection were going to be in that zone. The other reason I think that the site was chosen is that there was a service there that already had a very strong and positive relationship with people who inject drugs. And that's perhaps one of the primary criteria I would suggest for thinking about where you site a service such as an injecting room. The North Richmond Community Health Centre already had GPs, it had a lot of other health services, it had a needle and syringe program, one of the busiest and strongest demand in the whole of the state. It was also close to public transport, could be easily accessed. So a whole lot of reasons why that was quite a reasonable site. One of the things we tried to do in looking at the data, and I just wanted to spend just a moment or two on data, because a lot of people will quote things from various sources about, well, what about this and what about that? I spent weeks, days, many minutes looking at specific data. If, for example, we take the coroner's court data and the coroner's presentation to the parliamentary inquiry, it suggested there'd been 35 overdoses in 2015, just in that particular zone. Now, one of the things I looked at was, okay, what happened between 2015 right through to now, well, the then now, 2019. And one of the things I became aware of that people may already understand and know is that coroner's data changes. As investigations close, they may be 2 or 3 years or more after someone's death. And so it's quite tricky to get, well, what is the number for that particular year or for this particular period? So I'm just mentioning that because I know some will say that some of the data we've used might be wrong. And sometimes we've quoted historic data. So we've quoted something from a parliamentary report, or we've quoted something from the state statistics of the time that have now shifted or changed. So just to understand that about the coroner's data. Doesn't change substantially though, and there was clear evidence that heroin use and overdose deaths from opiates, this was definitely a hot spot, and actually the hottest in the state. The second lot of data that people suggest we go to is needle and syringe data. And this is actually also much more tricky than one might think. Because the actual records often show where equipment has been warehoused rather than where it's been distributed, it's actually very difficult to use the data on NSP availability to really be very clear and be very sure about exactly what equipment was handed out in which locations. And of course, there are mobile services, which also make that a little trickier. When we look at collection data of used injecting equipment, there are similar complexities, particularly given that from time to time, various councils, including the City of Yarra, have concentrated efforts on cleanups. And when that all gets bundled in, it starts to look really different to what it might have been 3 months earlier. So using that as an indicator of the extent of activity can be tricky. Looking at crime data, some quote police association data, which is often quite different to the formal Crime Statistics Bureau here in Victoria and their data. So looking at that and unpicking that and trying to understand how come it's different and what are the differences can be complex. Ambulance data is also quite tricky and complicated to assess. I won't go into that now, but a lot of time was spent and accessing a lot of expertise and tracking down how come this is different to that, at what point are we taking the data, what are we really looking at, what geography, and so on, can be much harder than one might think. We did also look at data such as the Hansard from the parliamentary inquiry. So I was very keen to see and understand the various views that had been expressed in the parliamentary inquiry. And we did a brief content analysis of Hansard and all of the issues that had been raised in that. Similarly, across the submissions to the parliamentary inquiry about the establishment of injecting rooms. And those people who'd made submissions or organisations were all invited to make submissions to us. Some chose to do that, others did not respond. And then, of course, there's all the qualitative data, the consultation meetings, the meetings that members of the review panel attended, often just staying in the background, usually as observers or watchers, such as the community meeting that was convened by the Yarra City Councillor, Stephen Jolly, in the All Nations Hotel, I think in about May last year or somewhere around about then. So putting all that together was actually quite a challenge. The selection of the site was not part of our formal task, but I think the international guidelines and the international environment is also interesting and somewhat telling. At my own expense, I chose in April of 2019 to go to Canada and to spend a week in Vancouver and about 4 or 5 days in Toronto, just to meet with, to have a look at, to walk the streets, to understand the context of the issues that they were facing and the responses that were there. And I found that an extremely helpful addition to my earlier professional visits over many 2 or 3 decades to some of the European injecting facilities. So I felt as though that was helpful in giving me some understanding of the range of injecting facilities that might be possible, what some of the issues were, and which ones were closest to ours. The one that we've had in North Richmond is what would be referred to as a high threshold, highly clinical model, where we've got doctors, we've got very well-trained staff, the environment itself is extremely clinical, and all of this makes for some attraction for some people and a detraction for other potential service users. The last thing I'll say about this is that these issues really point to a much broader dilemma, I think, what might be referred to as one of the wicked problems of our era: how to save lives, prevent harm, while also managing harm to local communities, harm to other residents, harm to businesses. And what do we do to ensure that the citizens who live and work in a particular geography are also comfortable and can go about their daily lives without fear or without living in a zone that becomes unlivable? Maybe I'll leave it there, but I think that's one of the dilemmas and one of the struggles. It's perhaps worth adding, though, that most or many international facilities do not claim nor try to improve amenity, though this one did, and it was clearly one of the objects or intentions of the Act of Parliament that allowed for the North Richmond medically supervised injecting room. So just to signal that is probably one of the areas of uncertainty in terms of achievement. Some things were achieved, but not all.
Thank you, Margaret. If you do have questions, you can drop them into the Q&A section, which a few people have done, and we're just going to go to a couple of questions now. One from Kevin Myers, who is asking about that the public perception of injecting drug users as being thoughtless about the effect on other residents, and whether or not the trial changed that perception due to the high number of people using the facility.
Thanks very much, Kevin, for that question. I certainly learnt by talking with a lot of the service users, that is people who inject drugs in the injecting room, but I also walked and talked and spoke to some who don't use the injecting room, but who inject in the vicinity. For example, I had an interesting half day when I walked with Uncle Colin, the Aboriginal liaison officer from the Yarra City Council, and I had a very interesting conversation with a cluster of Aboriginal folk who were not concerned to hide from me the fact that while we were talking, they were sharing a deal, they were sharing their experience, they were injecting one another. And in doing that, they explained to me that the reason they don't go inside the facility is that they feel they're very much from a sharing culture, and they put their money together in order to be able to buy their drugs. And having done that, they want to be together when they use. So going to the particular issue, though, of whether they are unthinking, selfish, and just determined to get their drugs, no. Most of the people I spoke to, both inside the facility and outside the facility, said they were very concerned about what injecting drug users did in relation to how other people in the area felt. And they were wanting to do something to help prevent that being bad and bad news for the service and for them as people who wanted to still be able to access both their drugs and a place to inject them. And in fact, many international centres, such as the one in Richmond, over time managed to use that commitment of the service users to establish groups that help to then train and encourage users of the service and people who inject drugs in the area to be sure to try and avoid bringing a bad rap or bad reputation on those folk. And some of them have got quite organised voluntary groups of users who will go out and do some of the cleanup and pickups. We'll actually go out and identify people who are injecting and not using the service and encourage them to go in, and who get very involved, for example, in putting together needle and syringe packs for people. So I don't think it's right that people who inject drugs don't care about what's happening to other people who live, work, and move through the zone in which they operate. I guess you'd have to say there are clearly some who, when they're intoxicated, might find it difficult to think about other people. But most of them, even when intoxicated, even when they've used their drugs, even when they're hanging around, feel concerned that they might be bringing bad reputation to the service. And that was actually quite prominent among the service users and those from outside the service. So back to you, Nick. Are there other questions?
Yeah, I think Sam Biondo, there was a question from you, Sam.
Yeah, Margaret, I don't know if you'll answer this or not, but the question relates to, I suppose, decriminalisation on the one hand, but also pragmatic policy development in alcohol and drug policy in Australia. For example, I know in the Netherlands, they've actually reduced the number of deaths related to heroin to just a handful, and they've actually wiped out the street market for heroin by regulating supply, and also putting in place a whole range of treatment supports and regulated supply to those that have substance use issues. So that combination of a regulated supply, saving lives, and busting the model for the mobsters that are making the money out of it should be something we should be thinking about. It also provides to me some sort of way through this localized solution approach that we have. You know, we'll put something in North Richmond, we'll put something in the city. What about all the other hotspots? What about the rest of the state? Do you think we'll ever move along this path?
Well, I won't try to get into the discussion about which international drug policies would be most appropriate to us here. I'll just say that I think what drives me and has driven me across my 50 years is to try and find a way of being both humane and pragmatic. And I think that if we are trying to take care of the people who are injecting drugs, then I think we have to try and find ways of allowing for that, our care for them, our preventing them dying, our preventing them getting sick, ill, our work to try and encourage them to continue in their other roles in the community, whether that be as partners or parents or family members or workers or socially, whatever. I think we've got to try and look at that, but also look at what works. And it does seem to me that those bigger debates that you mentioned, Sam, are relevant. I don't think it's for me, and it certainly wasn't part of our review, to have a look at issues about, well, what else in the bigger firmament of drug policy could be changed. I mean, I separately perhaps have some views on that, but it certainly wasn't part of the review.
Adam, I think we have a question from Horace about eligibility criteria.
Yes, and I was going to ask this as well, Margaret. It's Adam Willson, Fitzroy Legal Service. We were involved in providing service to the people who use the MSIR, along with other health services in the city of Yarra. And what's been a major concern for us, not that the primary concern is potentially, as Megan Fitzgerald, my colleague, has said in the questions, is the fact this criminalised frame of drug use. But the fact is that there are still some of what is already a very vulnerable community, but potentially the most vulnerable, that are still excluded through the legislation from using the MSIR. The report, obviously, the evaluation addresses that and recognises that many of these are going to inject anyway. In particular, I'm talking about those excluded who are pregnant, those who are under 18, and also those who we work a lot with as well, who have court orders stipulating that they cannot use drugs, or they're on parole and there's an exclusion from using drugs in them. Margaret, I'm interested from you personally, and also from the findings in this, going forward, do you have any suggestions or any opportunities that potentially raise their heads during this evaluation to to make room, to make it a more inclusive place for all people.
Thanks very much for that. And certainly the contribution of the Fitzroy Legal Service in my 50 years experience has been a very important one for this sector over very many decades. Look, I might take this as an opportunity to move, if it's okay with Nick and with Peter, onto the third topic, which is the achievements and the work still to be done, because I was intending to address the exclusions issue under that. So are you okay, Adam, if I proceed like that? So I'll get to exclusions.
Yeah, that's fine.
I'll get to exclusions. But I do want to just talk, before we go to some of the difficulties or lessons learned or work to be done, to some of the real achievements. I think what a lot perhaps don't realise is what an enormous achievement it was of North Richmond Community Health to actually start this up in such a short time and to be ready and to have staff and to be willing and available. They really only had a few short months to recruit staff, to train them, to become familiar, to get it happening. And that was a very significant achievement that shouldn't be just written off. It takes a lot of effort. The second thing I think they've managed was to attract people who inject drugs. They'd been told by the Sydney service, for example, the Medically Supervised Injecting Centre in King's Cross in Sydney, that it'll take you some days or weeks before anyone will come through the door. It takes a long time to build up the trust that you need. It takes a lot of effort to attract people who come into your service. This service was overwhelmed with people on the very first day of opening, and it has remained thus ever since. So that speaks to the work that was done in preparation and the fact that North Richmond Community Health already had a very constructive partnership, trusted relationship with people who inject drugs. So they didn't have the long, slow build-up. They were dealing with people who were injecting drugs from day one, and that really hasn't stopped. And so the demand, the people accessing the service has actually been extremely high. And that's partly what was behind the push along the way, moving from the transitional facility, which was on the side of the Community Health Centre, to a separate build next door to actually increase the numbers. Of course, under COVID-19, that's had a significant impact on what's possible with social distancing. And I really want to congratulate the management and the staff of North Richmond and of the MSIR in getting all this happening. It's not that easy. Some of these start up and really have to close down because they just don't ever build that connectedness with the people that they're intending to serve. They have also established that they have saved lives. But in addition to that, they've actually connected people with a lot of other services. Among them, Fitzroy Legal Service. And a lot of those services have begun to deliver the services from the MSIR or the injecting room itself, from that facility. So it's allowed some experimentation, some trialling of how best to get the folk who go in there to inject connected to housing, connected to legal services, connected to having their needs met. They have managed a very high-risk service with a very high-risk population extremely well. And we really could not fault their day-to-day operational effort in trying to run this very clinical, very high-risk service in establishing a totally new service, which also allows the potential for other research that could be conducted there. I know there is some interest of the director in trialling the provision of substitute pharmacotherapies. Certainly they have, for treatment purposes, already commenced that with a number of people. But I know that they might, they're also looking at what else could they do to attract the people who are not coming or who are not attracted to come in. Some people do find the restrictions burdensome and don't use it. So Adam already spoke about exclusions, but there are others who prefer not to use it because it doesn't suit them. The culture of the very clinical environment isn't one that they're familiar with. And historically, injecting for most people has been an extremely private affair, not only private because of, for whatever reason, but private because of the stigma, the law, and all the reasons why people tend to not want to inject with others. Now, overseas, and perhaps we're seeing some of this here as well, as a result, people are injecting alone, and that certainly increases the risk of overdose deaths and overdose damage. And when they go and inject at home alone, they're particularly vulnerable. So there are reasons to try to attract people to facilities that we can provide. But the exclusions or the rules, both the exclusions in the legislation and then rules within the centre, is an arena that I think still warrants some further examination. And I mean, the specifics, young people are excluded. So if you're under 18, you can't use the facility. And what we really found is that although there are some who would benefit from using the facility, young people were not the main audience for this particular facility. And it was perhaps not going to be ideal that they be attracted in there. So that's kind of, if you like, a separate issue for young people, particularly young people who inject drugs. Pregnant women, it's one of my personal, professional senses of I wish I could have, the complexity of the issues around pregnant women and most particularly their children in utero were legally complicated, and I think that's the reason for the original exclusion. But I do believe that we do need to do further work on that. We had a very strong submission from the College of Obstetricians and Gynecologists really pleading with us to say that they should be allowed in there. I would personally like to have been able to do that. It was not easy to pursue the complexity of that and to develop up an appropriate set of recommendations and to get consensus on all of that among all five, what ended up all five of the panel members. So I hope that someone will do further work on that. The other exclusion was those who are on particular court orders or have been involved in the judicial system. And this is one that I was very concerned about and very wishing that we could do something about, partly because they are the most vulnerable in our community. Geographically, they already attend and participate in a number of other services that are geographically very close to the North Richmond injecting room. Surprisingly, perhaps, one of the very senior meetings we had with the police, Victorian police, near the very end of our deliberations, suggested to me that very senior police would agree that it would be better for a number of those people to have access to the injecting room. They didn't exactly say that, so I don't want you to quote me as saying they said that, but I do think there needs to be some good look at what the legislation actually says and then how well that is interpreted in the regulations that govern the actual service. So I think there's some regulatory and administrative steps along the way that could be explored that leave some potential wriggle room in that context, I think, for those who are excluded. The last thing I'll say about the exclusion is that the exclusion because of ambience, when the Aboriginal woman in the cluster I was referring to before said, we buy together, we use together. We're not allowed to use together in there. Gets to the actual rules that are set by the department and therefore by the government, which are not necessarily directly from the legislation. So I do think that a legal mind could have a look at what are the opportunities within the current legislation to actually explore what might be possible and how might that be done. So that's my best answer, Adam, that I can come up with. So maybe back to, I'm not sure whether it's
back to you, Nick.
Okay, so going through some more questions then. I think I'm just trying to see if we have actually answered them along the way. And if I have typed an answer to your question and you don't feel it has been answered, please let us know by answering that question. We're asking that question, maybe just slightly changing your terms. From Rob Rees in the questions, a question about review, looking at the global work around social prescribing, and could it be seen as something to trial in the injecting room in the future to bring about improved well-being and more integrated community?
Thanks for that, Rob. Certainly, I think that there are opportunities for a range of research, given that this service in North Richmond has managed to attract a large number of people who inject drugs. There may well be opportunities for research among the service group who come there. So the brief answer is yes, there should be opportunities. I won't comment on what sort of research would be wise to try and how it could be tried. I think that's for others, but I think there are certainly opportunities for research. Any others, Nick?
Yes, another question from Richie Goonan. So I'm sorry if I mispronounce your name. The accelerated implementation of MSIR is mentioned in the report. Is there anything to learn about the implementation of a MSIR a second time around? How do we bring local community on board and increase that community collaborative effort?
Okay, Richie, thanks for that one. And I think there are certainly lessons learned, and one hopes that they are learned. And I might, in a sense, take this as an opportunity to segue into the fourth topic, which is opportunities and lessons learned. The thing that's really important to understand is that at 18 months of operation, the MSIR in North Richmond is still extremely young in its early unfolding development. We had to look at it after 18 months. It had really only had 6 months of operation in the full facility, and even then was still unfolding aspects of its service. So it's quite feasible that once it's settled in, which might take 2 or 3 years overall, it will look somewhat different. So I think there's certainly still, it should still be seen very much as a work in progress. With regard to the implementation, I think the main thing I would say about implementation is that pragmatics suggested it had to be done quickly to allow any time for it to be established, get happening, to be able to be assessed. So I understand the rapidity with which it was introduced and set up. I think the main lesson learned is, and I had learned this and I understood this myself from my experience of establishing an alcohol and drug treatment, research, education and training service in the middle of a then relatively high concentration drug market, drug use area in Fitzroy, that you have to do a lot of work with local services, with local residents and local businesses to gain their understanding, their trust, and their cooperation. And I think one of the complexities was that the shared responsibility for doing that between North Richmond Community Health and the Department of DHHS was pretty complicated. With such a high profile, media watched and highly risky service being established, there was obviously a lot of effort put in by the department to try and set this up with rules, with expectations, with guidelines, with requirements. The service itself, I think, felt from time to time that they were not sure how much they could or should engage in discussion locally, and how much they could, both in terms of their resources and permissions almost, get very active in their local community where they already had some very strong links and some very strong achievements. And I think that was a big lesson learned. I think the importance of engaging local communities, local services, communities of interest, and providing explanations of what you're doing, why, how we might understand people who acquire drugs, who sell drugs, who use drugs, and who inject drugs, and their potential risks, and why we would ever set up a place where they could use these drugs, is a necessary part of trying to sort out and get the implementation right. Having said that, I doubt if there's ever been an injecting facility established that hasn't caused or produced some consternation among local people, local residents and local traders. You might, some of you will recall when Sydney first was opened, there was a lot of pushback from local traders. It was a service that received a lot of negative press for quite a long time, with a lot of attack. And yet within, I think, 4 years or so, it was the local traders who were asking for it to be retained, and that they saw it as of benefit. So this is part of, I think, the evolutionary cycle. And I think one of the lessons learned is more time consulting, more time looking at information and what the concerns might be, and then perhaps trying to address those might be the sorts of things that could have perhaps made a little bit of difference. But I think inevitably there will be pushback. So that would be my sense of it. So I guess the two things that I think are the lessons learned. One relates to amenity, and I think the amenity issue for the people who live both in the public housing towers in the immediate vicinity of MSIR, the issues for the school that is next door, the issues for the traders on Victoria Street, even before we had COVID-19 and well before the MSIR was actually opened, there were already significant difficulties, issues, problems, concerns, and noise, if you like, about these issues before MSIR was there. And I think trying to engage the community and trying to have the community engaged and involved in site selection is one of the lessons that I hope will be learned. And having learnt it, trying to think through how do you deal with consultation, how do you deal with amenity, who is best to deal with amenity, what's the police role, what's the role of security guards, which of course has now become kind of such a huge topic for us here in Victoria under the COVID-19 issue. I think all of that is part of what I would hope that the government and people of the City of Melbourne might learn from the experience of North Richmond. I will note that the panel was not at all involved in nominating a specific site. We were neither involved nor were we asked about the site that the government announced they preferred. I think it's positive that they've said the word preferred, and they've not, they've said they're not going to stick to it no matter what, which does suggest a process of consultation and engagement with the community, which I had strongly recommended was necessary as a part of site selection. We were asked to recommend a municipality, and we did convene a virtual workshop to look at that with the panel members and one or two experts on the data analysis. And it was through that workshop that we determined that the evidence pointed pretty clearly to us recommending that it be established in the city of Melbourne. We didn't go any further than that. We have elsewhere in our report spoken of some of the criteria that might be used, and I'm happy to speak to those if people want me to, but we did not recommend a particular site. We didn't say anything about the Victoria market, and we weren't asked about whether we agreed with that site or not. So it's not part of our findings. So perhaps I'll leave other comments to see what questions we might have, Nick.
Sure. Well, there's three questions that I think are asking something along a similar line, and it is about area and that sort of amenity. So from Judy Ryan wanted to address the part of the report that talks about the Honeypot Effect, which I've got up on the screen there. And I'll just read the first paragraph, which is one of the most common concerns historically for supervised injecting facilities and other drug consumption rooms is that they will bring people who inject drugs into an area who otherwise would not have come, a so-called Honeypot Effect. So I'll leave you for that one, Margaret.
Thanks, Judy, and thanks for tuning in today. I think that the Honeypot Effect for North Richmond had already happened well before MSIR had started. So it was well known among people, even we discovered people from overseas who were visiting Melbourne. They knew that if they wanted to access heroin, they should go to Victoria Street in Richmond. So there was already a honeypot effect in a sense because the market was already there. It was the known place if you were wanting heroin in particular. And I think the issue, we actually tried very hard to look at whether that effect had increased or been exaggerated by the MSIR. We could not find definitive evidence of that having significantly increased. It's probably true that some people who would not otherwise have come to that area might have come to the area, but some of the people we interviewed or I spoke with on Victoria Street said they'd come to have a look, but they wouldn't bother coming back again. They could source their materials they wanted back where they usually got them. But I think that kind of curiosity factor wasn't strong. So I can only say that the increase was not significant in that sense. We did, however, think that you could not just keep expanding the numbers of booths in an injecting room, such as the North Richmond one at the MSIR, without it becoming problematic. So we have said that we do not think that should be expanded any further on that particular site. There is no clear international evidence to tell us at what point do you tip the balance to actually end up having everybody then coming to one particular site or not. So that we couldn't comment on that, but we did have a sense, if you like, from a range of data sources and from our own experience of being there, that about 20 booths was the maximum that you could appropriately manage in a service of that sort in that kind of location. It's worth me perhaps just saying that my visit to Canada suggested that in some places there, they would have had 5 or 6 injecting facilities within one, perhaps 5 or 6 blocks, or they would have had different ones for different people set up with slightly different models, all within like a CBD or one little section of a CBD. So there was a sense that I think the research on honeypot effect is a work that's still ongoing. It's very hard to say whether there's an ideal number in any one facility. When you've only got one, that's all you've got. I think the Canadian experience over time will give us a better handle on what happens if you have a number of small facilities, perhaps not always attached to a clinical service that's specific to this kind of activity, but perhaps attached to homeless services, shelters, attached to other health services, community health services, and so on. Whether that makes a difference to the amenity of the local area. But we did not find a significant definitive increase in the concentration of people coming to that zone as a result of MSIR opening.
Few questions on the funding and the resourcing of this model, and whether or not it was enough to adequately address the issues around amenity and engagement. So again, sort of flowing on from that theme, from Vera Boston asking exactly that question. Bo Lee also asking, was it optimal governance model with the current arrangement with the DHHS overseeing things? And yeah, I think all of these questions are asking a similar thing. Also from Megan Fitzgerald, although that might be, we'll see if we have time for that because we've got about 10 minutes left.
Thanks, Nick, and thanks, Vera. Good to know you're still there. I think that the administration and the management of it is something that we spent some time looking at. I don't think there's much chance that the department and the government over such a high risk, high profile service will completely hand over. But I do think that some of the complexity of what then occurs about a service in its locality becomes confusing for some of the participants. And we felt that I think that there is some advantage in that being further explored between the minister, the department, the service itself, the oversighting service. I mean, one of the things we came to understand is that North Richmond Community Health had been relatively long established and had serviced its local community for a range of services. But it probably did not have the experience that some other community health services that are bigger and have got perhaps more available sections or experience, such as communications. So it was exploring that. It's my understanding that the communications responsibility was initially with North Richmond Community Health, but in trying to fulfill the requirements in the implementation of that, the North Richmond Community Health CEO then asked whether, or ceded that responsibility back to the department because it became so difficult and complicated. And I think there are issues there about how services manage themselves and what the governing guidelines and implementation arrangements are. I think certainly if you're involved with a service that's looking at provision of an injecting facility, sorting out roles, responsibilities, rules, administrative expectations would be one of the foremost things to try and have clear before you start. Because once it's involved and engaged, it becomes a little tricky. And I think at times, the service itself was unsure about what it could be saying publicly and how much responsibility it had. And that probably made for difficulty in helping to manage the local area, local residents, local services, where they had a historic relationship and way of very openly discussing things, and then felt somewhat perhaps constrained by the expectations.
And we're nearly out of time, so I'm going to roll the last three questions into one, but I think they're all asking a similar thing again. And this is about sort of, I guess, the next steps. And Strunks was asking specifically about the term facility, whether or not the language around how these are described might affect whether or not people come to it. Megan Fitzgerald is asking about political opportunities for extending the health purview across the social justice environment, and Chloe specifically asking about advocacy for future injecting facilities, or whatever the language happens to be, because that is part of that same question, I think, and any advice that you might have for community groups. Sorry, it's a lot of a lot in one, but I think that will be everyone's.
Okay, not sure I can cover them all, but the word, I must say that initially I was hoping to use the word facility because I just didn't want it to be thought of as a room, because there's more than the room. There are a whole range of other services available at the facility and linked to the facility. And naming it becomes tricky. And the reason that we went with room is that was what was on all the contracts, that was what's on all the documents. And yet if you actually go back to the parliamentary and the legislation, it's not always room. So this issue about naming is one that we actually spent some time on. I kind of gave up and I said, all right, let's call it the medically supervised injecting room in our report, because that's what it knows itself as, and that's what the contracts say. So I think it's certainly worth having a think about that. You know, Sydney is a centre, so I don't know if that's helpful. And it's worth thinking about what's happening in New South Wales, not under COVID-19, but more around the efforts up there. I think there's a number of signals that they may also be looking at a more than one injecting facility, room or centre for New South Wales. The health, social justice environment, certainly if we look overseas, there are a range of different auspicing services for injecting facilities. And I think into the future, it's probably worth really examining that. Are there opportunities to provide services that might be auspiced with a particular focus on homelessness or on post-prison populations or any other, general health? One of the things that's worth saying about health, a lot of the people who present have got very poor primary physical health as well as mental health problems. And trying, as the Royal Commission is, to sort of have a look at how well is our mental health system work with our physical health system, I think just gives us an example of how complicated this actually is. And my experience on the Multiple and Complex Needs Initiative told me that unless you've got stable, safe, secure housing, the rest is all too hard. You can still do it, but it's really hard. So I would always put housing into that mix. Interestingly, in Vancouver in recent times, I understand that there have been established a number of units or houses that will allow to have a room on the ground floor of the units of, say, a 2 or 3 story set of units designated as social housing, and a supervised room on the ground floor that allows for people to inject. The advocacy one I will hand to others. I have to say that I'm anticipating this as my retirement gig. I'm trying very hard to retire. I did promise the family I'd retire by the time I'm 70. I didn't achieve that, but I've got my 71st birthday coming up in August, and I've got to try and get out before that arrives. So thanks very much, everyone, for your questions, your interest, and I draw your attention to the links to the full report, which includes a much more detailed executive summary than the summary report. So if you want to read a bit more, but not the whole thing, if you go to the full report, you'll see near the beginning of that a detailed executive summary, which is about 3 times as long as the report summary link that you've been offered. Thanks, everybody. Thanks, YDHF, the forum, been a very important service for this. Thanks to VADA and your engagement, your understanding of the needs of people that you service. And thanks to everyone who's tuned in, and particularly to the users of the services and to the staff and to the people who shared their experience, knowledge and data with us. Thank you.
Margaret, just on behalf of everybody who tuned in today, I'd like to thank you for such a thoughtful presentation. And the things that come to my mind is you are a great humanitarian, and your kindness and your consideration comes through in everything you do, everything you've said and everything you've done. And in the times of COVID-19, I think we should all take time to think and reflect on how much kindness we need in our community and how we should listen to one another more and more. And on behalf of the Yarra Drug and Health Forum and VADA, we thank you very, very much for your time today. And the forum, the Yarra Drug and Health Forum, stands ready to work with anyone to bring more compassion and humanity to the city of Yarra around the issues of drug and alcohol and the harm that it causes, and the need to find solutions that include everybody's needs. So thank you very much, Margaret. Cheers. And thank you everyone for joining.